Now I invite the second presenting person, that is Dr. Pankaj Kundra. Sir doesn't require any of the introduction to any of the faculties sitting here, and all the PGs should hear the sir's talks because it is such an important topic. So the sir is the Professor and Dean at JIPMER and Pondicherry University, and the professional body affiliations are Indian Society of Anesthesiologists, All India Difficult Airway Association, Indian Society of Neuroanesthesiology and Critical Care, and Association of Obstetric Anesthesiologists, India. The achievements are the UGC academic achievements, UGC sponsored fellowship, that is ultrasound applications in India, WHO fellowship intensive care, WHO fellowship in interventional pain management. The awards are YG Bojara Award 2019 and 22, origins are 10, and chapters in book 10. The positions held are former Dean Academic JIPMER Pondicherry and the President of All India Difficult Airway Association. And the publications are peer-reviewed journals 147 and the PubMed in 117, and the citations and 21912, and the index is about 30. That is, because of all this, we have to hear the important topic that sir is going to discuss about the vaporizers. Over to you, sir.
Very much, ma'am and chairpersons. A very good morning to all of you. Thank you for so comprehensive description. It's an honor to be here, and thank you organizers for giving me this opportunity. Now the topic is about construction of a basic vaporizer. They said vaporizer, but if I go to modern vaporizers, it will be out of context. So let's talk about the physical principles on which the vaporizer should be based on. Remember, it is dispensed in liquids, all the volatile agents, and then it has to be converted into a vapor form. So normally what you do is that when you want to set a concentration of an anesthetic agent, you do dial setting in volume concentrations, 1%, 2%, 3%. But the gases exert their effect in partial pressures. So the same gas or vapor which goes through a vaporizer into the lungs, if it has to give you an anesthetic effect, it will be by the partial pressures. So we set the concentration in percentage, but the effect is actually by the partial pressure. So how do we determine what is the partial pressure of an anesthetic agent? This is a simple formula, and if you look at what partial pressure would be, that is what you have set on the dial divided by 100 into the total pressure, which is the barometric pressure. So if your sevoflurane concentration is 1.8, that is 1 Mach concentration, and therefore the partial pressure of sevoflurane that will be exerting an effect is 13.68. So actually volume percent of alveolar glass at 1 atmosphere should normally be termed as P Mach. So Mach concentration is not the minimal concentration, but it is the partial pressure of the anesthetic agent, which is required to produce immobility to a noxious stimulus. So that's the revised, or that is how the definition of Mach should be. So if you look at Mach of desflurane, it is 6. Then the P Mach 1 of desflurane would be about 45.6. Now what happens if we take these vaporizers to a higher altitude, or you want to make sure that your vaporizer, which you are going to construct, also works efficiently at a different altitude. At sea level, the barometric pressure is 760, and these are not pressurized, the vaporizers. So if you look at the sevoflurane at 1.8%, the exerted partial pressure is 13.68. But at 10,000 feet, if the barometric pressure is 380 millimeters, you'll find the vapor pressure of the sevoflurane has actually increased. Because in a basin, if you look at the vapor pressure, the atmospheric pressure plays a role. So if the atmospheric pressure is reduced to half, the vapor pressure would be doubled. That's why if you're setting it at 1.8, the actual volume of sevoflurane which is going to vaporize would be 3.6, that is double, right? Because the atmospheric pressure has halved. And therefore, it will exert a similar kind of Mach pressure. It will not change. So if these kind of vaporizers are taken from one altitude to another, the delivered partial pressure of sevoflurane or an anesthetic agent would be the same. But it will not be same for desflurane, because that is pressurized at 2 atmospheres. So the vapor pressure of desflurane will not change, and there would be a change in the Mach P of desflurane when you take it to a higher altitude level. So that is one thing which you must remember, that despite 2-fold increase in the volume percent, the saturated vapor pressure increases, but the partial pressure remains the same if the vaporizer is not pressurized. How does this process of liquid to vapor conversion take place now? So that's the main way which we want to understand. So we look at these 2 vessels in which a liquid is placed, and if a liquid is left open, there will be some evaporation which will take place. That's how your clothes get dried up, right? Because there is evaporation, which is a continuous process, and all liquids have an inherent property of latent heat of vaporization. So that heat enables those molecules to come to the liquid surface and evaporate. However, when these vapors exert a pressure onto the walls of the container as well as the lid which is covering it, that is what will be called as a vapor pressure. So what is the difference between vapor pressure and the saturated vapor pressure? When there is a constant vaporization, that is, the number of molecules which leave the liquid surface is constant to the number of molecules that are returning back to the liquid interface. At that pressure, the volume of air in that compartment is saturated or is having a constant vapor which is being generated from the liquid surface. So if you have constant vaporization, that vapor pressure would be named as the saturated vapor pressure. But since it is a dynamic equilibrium, this constancy is maintained and it is always depicted at a constant temperature. So we have understood that the amount of vapor, when it becomes constant in a container which is covered by a lid, the pressure exerted by that vapor would be the saturated vapor pressure at that particular temperature. Now, what is the boiling point? We start boiling a liquid, and you'll find that at the liquid interface, there is atmospheric pressure. So this atmospheric pressure is actually not allowing the molecules to escape the surface of the liquid unless the pressure inside the liquid exceeds the atmospheric pressure or is able to overcome that atmospheric pressure. These molecules will not be able to leave the surface of the liquid. And when it happens, that is when the saturated vapor pressure equals the atmospheric pressure, that would be the boiling point of a volatile agent. So if there is a low barometric pressure, there will be a low boiling point. Therefore, if you want to increase, or if the liquid has a low boiling point, and if you want to increase its boiling point like desflurane, you will have to increase the pressure. And that is precisely why you keep desflurane at 2 atmospheric pressure, so that the boiling point of that liquid can be increased. Now, the purpose of the vaporizer is to accurately deliver concentration, and you can adjust the concentration which is required. And this is basically achieved by the saturated vapor pressure. So the saturated vapor pressure, in a sense, is the sole mechanism through which you will design how vaporizers can be calibrated and how constant concentration of vapors can be delivered. So remember, the definition was at saturated vapor pressure, the number of molecules which are escaping are always constant. So if they are constant, then this is the property which will help us to make the vaporizers more accurate and deliver those concentrations. So what is the concentration of anesthetic vapor in a gas? So gas concentration, as we already described earlier, would be the vapor pressure divided by the ambient pressure. So at 20 degrees centigrade, if you have isoflurane in the vaporizing chamber, what will be the concentration? The saturated vapor pressure of isoflurane is 239 by 760, so you will have 31% of isoflurane that will be vaporized. That's the concentration you're going to get. But would you be able to deliver that concentration to a subject or a patient? We deliver 1%, 2%. We can't give 31%. So somewhere this 31% has to be taken care of. So how do we do that? You'll have to do either dilute the carrier gas so that the concentration in the carrier gas is reduced, right? Or you have to control the concentration so that not all 31% is delivered, only the required therapeutic concentration is going to be delivered to the patient. So this is what the vaporizers do for us. So the concentration calibration is done by either diluting the carrier gas and by controlling the concentration. So let's talk about the carrier gas flow first. If it is a variable gas bypass chamber, there has to be a splitting ratio. That means some of the gas bypasses the bypass chamber and only a minute quantity of gas goes through the vaporizing chamber, which gets saturated and gets mixed with the carrier gas so that the final concentration is what you want to deliver as an anesthetic, not 31 which we are getting there. The other way of doing is you have separate flow meters for the anesthetic agents, and you direct these fresh gas flow through the vaporizing chamber and then deliver it to the patient. And these are measured flow vaporizers which you can get. So what is the splitting ratio? It's the ratio of the bypass gas to the gas which is going through the vaporizing chamber. So if your dial setting is 1%, it means that 46 liters or 4,600 ml of gas is bypassing the vaporizing chamber, and only 100 ml of that gas is going through the vaporizing chamber, and that will give you a dial setting of 1%. So that is what the splitting ratio does when you design a vaporizer, so that it is specifically meant and calibrated according to the saturated vapor pressures. So if the dial setting is 2%, you'll find an equivalent, the amount of gas which will be bypassing, bypass would be much less. It will be 22. So the idea here is to remember that if your saturated vapor pressures are the same, you probably can use the same vaporizer, but because the splitting ratios would be almost the same. But if the saturated vapor pressures are quite different, then you cannot use the same vaporizer for the other kind of a volatile agents. So these are agent-specific vaporizers which you will be using. So the vapor output, as we have discussed, would depend upon barometric pressure, boiling point, and splitting ratios. Now what about the other three? That is the surface area of vaporization. So this is what we will call as a plenum type, where you need to know that if a variable bypass vaporizer is created, what is plenum type? Plenum type is something which increases the resistance to high resistance, and low resistance is where there is no resistance at all to the bypassing or the fresh gas flow. So the fresh gas flow, it is above the atmospheric pressure, then it will be a plenum type, but if it is at atmospheric pressure, it will be low resistance type and is generally driven by the patient's respiratory efforts. So in a low resistance vaporizer, you will find that the gas will come It will take away whatever molecules are there from the surface and be delivered to the patient as the patient is breathing spontaneously. But when you increase the gas flows, you'll find that much amount of gas being wasted, because only a particular portion of the gas can come in contact with the liquid surface, and that is why most of the gas would be unsaturated. So this is a disadvantage. So when you want to maximize the area of surface of vaporization, create some resistance, create narrow channels so that all the gas which is passing through the vaporizing chamber is saturated with the anesthetic vapor, you'll need to create such kind of mechanisms. That is so that the surface of vaporization or the area is increased and you can maximize the concentrations. So these are the plenum types, and to develop a plenum type, it will be something like this. You produce convoluted tubings which is going into the vaporizing chamber. This is the bypass gas which is going through. But this gas would have to go through these convolutions. These convolutions are lined by wicks which get saturated by the volatile anesthetic, and you create such baffles so that you increase the queue or increase the time and narrow the channels through which the gas is going to go through, so that there is more time taken and all the gas which is passing through the vaporizing chamber is saturated. So this is how you generally increase the resistance, increase the area of evaporation. So these are more accurate types, and that is how the vaporizers normally are connected. So next comes the effect of gas-liquid interface, whether it is a draw over or a bubble through. Now OMB was one of the vaporizers where it was variable bypass, so that it had one gas which was bypassing, the other was going through the vaporizing chamber. It had metal mesh wicks which were there, low resistant type, and multiple agents could be used. But the problem is when the liquid is vaporizing, the temperature will fall, and that will reduce the vaporizer output. So there was no temperature compensation which was included into this. So this is how it worked. This is an OMB, and I drew this thing to tell you how it works. So this is the bypass gas. The other gas is going through these small holes. They go through, and all the lining here is by the wicks, and there is a water bath which is trying to give some heat to the liquid, but it was not actually giving you a proper temperature compensation. So these were the vaporizers which we used. These were multi-agent vaporizers which could be used. But, just an example of how the plenum type of vaporizers can work. Now coming to the temperature of the liquid, how do we go ahead and do the temperature compensation or overcome the cooling effect of the vapor output? So the fluctuations can happen in the ambient temperature because of the loss of heat of vaporization, and these problems are overcome by temperature stabilization or temperature compensation. So temperature stabilization are achieved by using specific material which have high specific heat and high thermal conductivity, but the thermal compensation, you'll have to have separate mechanisms devised for them. So if I can take 5 minutes extra. So specific heat, generally if you look at copper and water, you will find it is basically the heat storage capacity. How much heat can it store, and it can give it off to the agent when it is vaporizing the liquid agent, and so that some sort of heat stabilization can be achieved. So if you look at copper and then if you look at water, these are the best combinations which you can achieve. Thermal conductivity is heat sink, how fast the heat travels between the vaporizing chamber and the atmosphere. So these are the two physical principles would be involved to actually select the material which you want to use to conduct the vaporizer. And if you look at the combinations, you'll find copper comes the first, and second is the aluminium, because here you find the specific heat is the minimum almost here. Air has minimum here, but look at the thermal conductivity, it is the least. So that is the reason we need a good combination of these two properties to get the material which we need to construct a vaporizer. Thermal compensations can be provided by supplied heat, computer control, or splitting ratios. This is what we normally use. These are all used for the modern vaporizers which are currently in use. The thermal compensation is basically made of two metals of different coefficients of thermal expansion, and they are fixed together. So if the temperature is low, one metal would expand and it would bend over to the other. And if the temperature is high, this one will expand and the chip would tilt over to the left side. And that is precisely how it works. So it is placed at the inlet of the vaporizing chamber inlet. So whenever the vapor comes, if the temperature of the liquid here falls, it actually bends over because of the different thermal expansions and allows more of the vaporizing gas to come over so that the vaporizing output is not compromised at any point of time. The first time when it was used was basically for EMO vaporizers. They had a thermal compensatory unit which was installed, so that this was probably the first vaporizer which gave you a thermal compensation actually in where it was incorporated. So these were the control levers. If you look at it, you can actually also see how much percentage of ether is going to be delivered and how it happens. In this diagram, you will understand that this is a lever which is a spring loaded, and this is where you adjust the dial settings. So as soon as you increase the dial settings, the lever comes up and more of the gases will go into the vaporizing chamber. So the gases go into the vaporizing chamber. This is the small inlet. So this is altered by the lever as you turn it onto the left or onto the right. But when the gases have to come out of the vaporizing chamber, it depends upon the thermal compensation. This is a small capsule which was laid in here, and this actually delivered the thermal compensation. So there was a fall in the liquid temperature. This capsule will come down, increase the outlet so that more of vapors or the gas carries more of vapors and gets into the mixing chamber. And this was a freon gas which was put into that capsule. So tech vaporizers have all these mechanisms which were used. You will have to incorporate these mechanisms if you have to have a vaporizer which has to be constructed by a particular person. So all those hazards and safety mechanisms have to come up apart from the vaporizer output which you are looking for. So there are a lot of hazards and issues which can crop up, and you would know that pressurizing effect, pumping effect, these were the drawbacks of the vaporizers which were initially constructed, and they had to be overcome by subsequent modifications. So at low flows, there was issue. What was set was not delivered to the patients, and even at high flows, the same issues happened. So pressurizing effect, if you look at it, is simple, and under normal conditions, you'll find that the vaporized output is mapped. But as you increase the fresh gas flow, then what will happen is that the gas is compressed, more molecules per ml are generated, and the anesthetic vapor pressure is not altered, and the net effect would be decreased anesthetic concentration which is delivered to the patient. And pumping effect is something different, that during expiration the bag expands, and when you compress this bag, you push back the gases into the vaporizing chamber so that the anesthetic concentration in the subsequent breath which is delivered is increased. If you have two vaporizers which are there, you will probably have to incorporate a vaporizing interlock so that only one vaporizer functions at a time. And this is the rod which will block the other vaporizers, so you will not be able to turn on the dial flow of the other vaporizers, so that you don't deliver two anesthetic vapors at a given point of time. You will have to make them vapors agent specific, and these are the safety measures where you will have to have those collars and bottles which will have keyed adapters fitted onto them so that the same agent is put into the same vaporizer. So you have to make them agent specific, and such flaws should not happen. Mounting of the vaporizer also is important. You'll have to create a mount, and these are vaporizer stands which are vertical pins, and there is an inlet as well as an outlet. Each pin has a O-ring, and sometimes these get worn off and there will be a leak from there. So how does it work? This is a vaporizer off position, and this is the vaporizer on position where the levers are depressed and the spring-loaded balls are depressed. So when you switch on your carrier gas flow, only in this position, only in the on position, would the gas go into the vaporizer, otherwise it will not be allowed to enter the vaporizer at all. So this is the mounting facility which is provided in each vaporizer when you turn it off, and how do you turn it on. Measured flow vaporizers are easy to construct because you have separate regulators, for one which goes into the vaporizers and one of the gas which bypasses it. So it's much easier to control this, and both of them are then mixed. But how does it work? It works on the basis of copper kettle principles, where you have separate flow meters. The desired concentration of the agent can be calculated by the circular slide, but again the saturated vapor pressure is what it all comes down to. So the rate of two fresh gas flows which is going into the vaporizer and bypassing it is separately controlled by the operator, not by the vaporizer by itself. So to achieve 1% of concentration of sevoflurane, what will you have to do? So this is the this is the inflow to the vaporizer, which will be determined by the saturated vapor pressure, barometric pressure minus SVP. So if 100 ml is going through the vaporizing chamber, and if you look at this equation, 46 ml of sevoflurane would be saturating this 100 ml. Therefore, the total volume of sevoflurane would be almost 146 ml. And the one which is bypassing it will be 4.5 liters, and that will be the total amount of fresh gas flow which you will get. And if you divide it, then you will get 1% sevoflurane. So with that, I come to the end of my talk. Thank you for giving me that extra time. So just to give you a summarize, liquid to vapor phase, remember volume percentage and pressures are different. This is what exerts the anesthetic effect. Doesn't make a difference when you are at high altitude if the vaporizers are not pressurized. This is the most important one as far as saturated vapor pressure is concerned. And to optimize output, you need splitting ratios and these kind of mechanisms. Thank you, sir. Thank you very much.
Thank you, sir, for the excellent presentation.